Dr. Shahir Ahmed is joined or?
He is not yet joined. Is
Okay.
expected to join.
The contact number, just can you give a reminder?
Yes, sir.
Good evening and welcome to the fourth episode of Heart Failure Masterclass. Um, this is the fifth year we are continuing with this program. This is supported by the Heart Failure Society of America. So this episode we have a presentation by Dr. Tiny Nair on clinical evaluation in heart failure still relevant in the time of AI. Then followed by a case presentation from Jipmer Pondicherry, and the student panel will be from SIMS Tirupati. The examiners are Dr. Dayasagar Rao, Dr. D. Rajashekar, Dr. J. Balachandran, Dr. Santosh Sadish, and Dr. Sahir Ahmed. So we will first start with the talk by Dr. Tiny Nair on clinical evaluation in heart failure in the time of AI. Over to Dr. Tiny.
Good evening. Today we will be talking about heart failure management in a totally different perspective. And that is bedside cardiology, clinical bedside cardiology, its relevance today in the era of artificial intelligence. That what you see there on the screen is one of the newest CT scans called a photon CT. Now, photon CT not just identifies the coronary anatomy, delineates the plaque, but also sees beautifully through stents. And when you combine, for example, an IFR, you get a very strong tool which talks about the coronary anatomy and flow, structure and function together. That is the Nature Journal's first page, which talks about unraveling the human genome. Huge data. Today, it's in front of us. And finally, we always use the ChatGPT. So the whole point is, in this era where technology has gone to enormous levels and it's an easy reach of all of us, does clinical cardiology have a relevance? Now we have the poor physician here, the poor clinician, okay, armed with an ear with which he can hear, a pair of eyes which can see, a pair of hands which can perhaps touch. And the output, if you consider as an output, is his mouth through which he can speak. In the next about 12 minutes or so, we will show you that even today, if your hearing turns into listening, there's a difference between hearing and listening. If you visualize rather than just see, if you feel rather than touch, your speech becomes the word of wisdom. And that is clinical bedside cardiology in the background of heart failure. Now we know that in the 1950s, the main problem was asymptomatic assessment of a patient. A patient comes and says, "Doctor, I'm not well." The question is, how unwell is he? Maybe a marathon runner who is unable to complete a 10-mile course would say, "I am unwell." At the same time, a person who was in bed, walks to the washroom, would say, "Today I'm so much better." And the simple answer was here. What you see on the left is the New York City, and on the right, you see the Manhattan grid an aerial view. So you see Manhattan is basically a geometric structure where you have stacks of rectangles. Now, if you zoom that up, the stacks of rectangles, you see each New York block looks like this, where a New York block measures 80 meters in breadth, 80 meters in breadth, and about 275 meters in length. So 80 meters into 275 meters. Blocks. All blocks are identical. So it was easy, or rather intuitive, for the 1950s cardiologists to ask that how many blocks could you walk without getting tired? Okay. So it boils down to, okay, so you have two blocks together. You have two blocks together side by side. If you connect them, it is what? 160 meters. So you can see the New York Heart Association class emerging. So you say, a patient says that, yes, I can complete this 160 meters without a symptom. I might be having heart disease. So he is class 1. No symptoms on completing the 160 meters, which is to the patient 2 New York blocks. If he said, well, I can walk and complete, but I have breathlessness, I have chest heaviness, it is class 2. If he said that, well, I can't complete, unable to complete, is class 3, and what was defined as unable to start was class 4. So that is how clinically the NYHA evolved. And today we know that if we can complete more than, we have class 1 more than 7 minutes, class 2 is 5 to 7 minutes, and 3 is 2 to 5 minutes. So the metabolic equivalence of the NYHA was clearly underlined. Now the point is, today if you take, for example, heart failure outcomes in simple terms, on the left you have event rate, and on the right you have days. On the y-axis you have probability of survival. And if you look at that, okay, you have NYHA 1, 2, 3, 4. All that we're trying to say is, even today, if you take any study, NYHA class predicts outcome. So NYHA class even today predicts outcome 1, 2, 3, and 4. So yes, simple clinical parameters like NYHA is still valid today. So you would say, okay, what about in the background of high tech? Now, since so many new tools have come out for assessment of symptomatic status. We talk about the Kansas City Cardiomyopathy Questionnaire, KCCQ scales, where we looked at not just symptoms, physical and social well-being, quality of life. We look at the 6-minute walk. They're all tools. They're effective. They're even better than a vague NYHA. But NYHA still stands tall. For example, if you look at that is what? That is mitral valve transcatheter mitral edge-to-edge repair. Okay, we do it. One of the high-tech procedures that we do in mitral regurgitation. That's severe MR. You can see that post TER, there's no MR, right? So transcatheter mitral edge-to-edge repair is successful. So why we're talking about TMER? Because if you take this, one of the new reports of long-term outcome of transcatheter mitral valve edge-to-edge repair, right? And that shows that one parameter that clearly predicted outcome was NYHA class at 30 days. Best indicator of long-term prognosis. So what we're trying to say is that NYHA is not dead. Despite all this advancement, NYHA still stands as something that tells us about long-term prognosis. So clinical cardiology is not outdated. Now, let's talk about, let's say we have taken this 2023 ESC guideline for the management of cardiovascular disease in patients with diabetes. How does heart failure diagnosis go? We all know that first we look at symptoms. Second, we are supposed to look at NT-proBNP. Third, we are looking at echocardiogram. And then we are looking at the phenotypes. HFpEF less than 40, EF between 40 and 41 and 49, mid-range, and more than 50 HFpEF. So we have the symptoms like effort, angina, JVP elevated, we have NT-proBNP, we have echocardiogram, and then we have the LVF, right? That is how it goes. Now, today we tend to forget the starting point. The effort dyspnea, the elevated JVP, the clinical signs and symptoms. Straight away, going on to NT-proBNP, echo, and all that. So you might say, what is the problem? Is there a problem? Is there a problem? Well, we know the diagnosis of heart failure today is by echo LV ejection fraction. And of course, if you talk about diastolic dysfunction, HFAI, and we have the NT-proBNP. Without that, there is no diagnosis. Yes, we do agree, but pause for a moment and look at the data. Let's look at something called positive likelihood ratio. What is positive likelihood ratio? If you have a probability that a test is positive in a patient with disease. So a patient has a disease, heart failure, and the test is positive. That is true positive. And you divide that by probability of the test positive in patient without disease, false positive. So true positive by false positive gives you positive likelihood ratio. And what we say is that if you want to interpret likelihood ratio, look at the chart. If you have something between 5 and 10, you have more than 5 rule in. We say that you should always remember anything more than 5, you rule in a disease. Couple of 5s and you are sure that the disease is there. Positive likelihood ratio. Okay, now let us say a patient has come to the ER with dyspnea. So you're trying to see, is it heart failure? Is it some respiratory disease? Now let us look at likelihood ratio. If you have a history of heart failure, this patient in the past, he says, yes, doctor, I had a similar dyspnea and I was diagnosed with heart failure. The positive likelihood ratio is 5.8. If he has history of proximal nocturnal dyspnea, 2.6. If he has atrial fibrillation, 3.8. And if you can pick up a third heart sound, which we can easily teach one of our students, right? It's just a question of learning to auscultate, which we have conveniently forgotten. Third heart sound is 11.9. So singly, even a history of heart failure AS3 is a likelihood ratio of more than 5. And if you combine a couple of them, your values go up. But this is not what you're trying to impress. Look at that and hold on for a moment. Hold on for a moment. There's something in statistics called C statistics. C statistics tells us about the power of a predictive model. Power of a predictive model. We'll simplify it. So C statistics on y-axis has hit rate. So you're throwing something, you're right on target. So it's a true positive. And you x-axis, your false alarm rate, which means it's false positive. So basically you have a graph of true positive by false positive. And you are looking at the area under the curve. Let's say you have something about 50-50. So your chance the model fails is 50-50. Right? So C-stat is very low. Now, if your C-stat is, for example, 0.76, you see that curve there, first curve? That is C-stat of 0.76. Okay, the area under the curve is a little better. If you have a C-stat of 0.92, you're a little more better. And if you have C-stat of 0.98, oh, so much better. So what are we talking about? If you move up from a C-stat of 0.76, let's say 0.76, to 0.98, you are very good. So if you tell me that my model of prediction has gone up from 0.76 to 0.98, you will say, oh my God, this model is excellent. You will apply it in clinical medicine. Now, with that understanding of C statistics, let's go back to our previous graph, which we have learned, previous data which we have learned. 5.8, history of heart failure, PND 2.6, AF 3.8, S3 11.9. Now, on that model, this data is from the 12th edition of Grunwald, by the way, for the postgraduates. Look at that. On that model, if you add up NT-proBNP, which is our gold standard for diagnosis of heart failure, the C statistics moves from 0.83 to just 0.86. So if you have a clinical positive likelihood ratio as high as more than 5, adding NT-proBNP does very little to your model, which means, yes, to a sharp clinician, bedside diagnosis of heart failure still matters. Okay, now let's talk about small things. For example, this is a Schwann catheter. Many of the present-day PGs might not have even heard about it. It used to be a regular technique of putting in a catheter, wedging it in the PA, and trying to assess the PA wedge pressure. Right. Now let us see something simple. On the left, you see that you can't see the JVP, and then right, let us play it there. This lady has, you can see the JVP is elevated. Why? Because we have compressed her abdomen for 10 seconds. Abdominojugular reflex. What's that again? What's that again? Abdominojugular reflex is compression of the abdomen for 10 seconds, elevation JVP lasting for more than 15 seconds by 3 centimeters. And what does it mean? The moment you get elevated JVP, moment you get the PA wedge pressure is more than 50. So simple clinical bedside examination gives you a data like PA wedge pressure. So clinical medicine is still important, right? Clinical medicine is still important. And look at that. This is another JVP elevated, but this is a man who has hypertension, no heart failure. He walks around, he has no symptoms. Hypertensive elevated JVP. What is the reason for his elevated JVP? It is left ventricular hypertrophy. He is an hypertensive. So elevated JVP in a hypertensive with concentric LVH indicates hypertensive heart disease. Why we are talking about that? The point is here. If you look at his electrocardiogram, very clearly his large voltages, showing that ESO criteria has left ventricular hypertrophy. Left ventricular hypertrophy in an hypertensive, what is so special about it? The special is the moment you see left ventricular hypertrophy, LVH by ECG, this is old data from Framingham, look at that. The predictive value for cardiac failure is 15 times higher in men and 12.8 times higher in women. This is age-adjusted risk ratio. So the moment you see a LVH in an ECG, the chance of developing heart failure goes up by 15 times. So yes, left ventricular hypertrophy by ECG, we know that ECG is not a very sensitive or very specific measure of LVH, but if you detect it, it indicates that patient might go for heart failure. Bendopnea, a feature which we knew for such a long time but didn't understand its implication. Bendopnea is when the patient says, I bend down and I feel dyspneic. Now, bendopnea, we know that as we bend down, increases intrathoracic pressure and there is increased pulmonary vascular resistance. So as we bend down, the thoracic pressure increases, there's increase in pulmonary vascular resistance. At the same time, because there's increase in intra-abdominal pressure, there's increased venous return. So on one side we have increased venous return, the other side we have afterload of the right side increasing. And so the patient feels dyspneic. Right. Now we are not going to the hemodynamics. The point is bendopnea tells us so many things. Not just that he is obese, but that bendopnea indicates increased RA pressure, increased PA pressure, LVEDP is high, obese, AF, and HFpEF. So the moment we see or listen to a history of bendopnea, you should think about connecting links of HFpEF, obesity, and AFib. Now, for example, yeah, that is an AF, but then to diagnose AF, you don't really need an ECG, right? You can clinically examine his pulse, JVP, and make a diagnosis that is atrial fibrillation. And if you look at the echo of a HFpEF patient, we know that there is LVH, there is large LA, and that's it. Don't even need to go into diastolic dysfunction, right? So if you have a left ventricular hypertrophy by echo and a large LA and history of bendopnea, you might be dealing with HFpEF. Why we are talking about that? The point is, for example, let us take the H2FPEF score that we use for HFpEF. Okay, in HFpEF, for example, if you have a patient who is obese, heavy, the body mass index is more than 30, you get 2 points. Hypertensive, 1 point. Clinical AF, 3 points. And if he's, so what, 3 plus 2, 5 plus 1, 6. And if he's elder, more than 60 or 1 more point, 7. So understand, you've not even gone into his echo. You've not even gone into any investigation. Clinical AF, hypertensive, heavy, elder. And you have what score? A score of 7, which means very high probability of HFpEF. Well, if you are looking at filling pressure, gasoline dysfunction, Doppler E prime ratio, that's different. We are not going to that. The point is clinical cardiology is still alive. And you can make a diagnosis of HFpEF, which many of the postgraduates would have forgotten. As with clinical medicine, you can make a diagnosis of HFpEF, even without knowing the diastolic function of the heart. Right. Now, yeah, carpal tunnel syndrome. But then when you are talking about somebody with an HFpEF, heart failure, you know what we are talking about. We are talking about ATTR, right? And today ATTR, we are detecting far more than what we were doing today. Why? Because clinically we keep our options open. The moment we, this is one of our patients who is who came with an atrial fibrillation, you can see that small voltages in the limb leads, classical, echo showed a significant wall thickening. This was this technetium pyrophosphate. The cardiac uptake is as high as the sternal uptake, and that report clearly showed that she has got ATTR, right? Because there's something which is enormously treated or treatable condition to me. So the point is that ATTR, the points that tells the clinician that there could be an ATTR in addition to an HFpEF, or we carpal tunnel syndrome, a lumbar canal stenosis, unconnected, spontaneous rupture of the biceps tendon. These are indicators that you might be leading, your HFpEF patient might be having ATTR, and a simple technetium pyrophosphate and maybe electrophoresis would give you an idea whether you should go forward with your diagnosis or further workup. We'll finish with that. We know this is a simple BP apparatus, but then those postgraduates who work with us know that we invariably so often take a lower limb blood pressure. Of course, apart from Hill sign, that is because the lower limb blood pressure, if you look at the upper limb blood pressure and take the lower limb blood pressure on top, we get the ABI, the ankle brachial index. Ideally, as per textbooks, you need to use a Doppler probe. But forget about Doppler probe. Just your normal arm cuff, and if you palpate the dorsalis pedis artery, you get a fairly good clinical sense of an ABI. And we know that if the ABI is abnormal, if you are dealing with a peripheral arterial disease, the chances of having a coronary artery disease and CVD or both are extremely high. 65% of POVD patients has CAD. So all our doctors who have worked with us knows that we start our examination with the lower limb pulse. Today's PGs are forgetting that, but remember that this is so important. Why? Because the moment you see, okay, there's a dilated cardiomyopathy, there's a 55-year-old male class 2 DOE, turned out to be dilated cardiomyopathy, NT-proBNP 8,900. But the point is, once we saw the abdominal ABI, yes, we know that he has to undergo a coronary angiography. And then before we diagnose as an idiopathic dilated cardiomyopathy, yes, the angiogram shows clearly that he has got diffuse TVD. So the point is a simple ABI could tell us about the presence or absence of underlying coronary artery disease. So ABI is a simple tool that tells us in the background of heart failure whether a patient could have a underlying CAD. So what we are talking about finally, yes, we know the base theorem. So we have pretest probability, and that pretest probability decides about the post-test predictive value. Whatever sensitive your test is, be it a high-level scan or a biomarker, that is important to understand. So if you look at the entire picture, let us say you are looking at a patient background, clinical background, with a very high likelihood of a disease. And if the test is positive, very likely has a disease. And if the test is negative, very unlikely that he has a disease. But the point is, if you clinically pick up somebody who is unlikely to have a disease, a young lady, very unlikely to have a coronary artery disease, even the treatment test is positive, he still is unlikely to have the disease. So a test which is positive for a person who has a very low pretest probability tells us it's very unlikely to have a disease, right? So the point is, finally, bedside cardiology is not outdated. It tells us when or not to use your high-tech scans or a biomarker in heart failure. So we repeat, clinical bedside cardiology is important, not outdated. In this era of AI, where we are so tuned to high-grade scans, high-tech, high-level, cutting-edge technology, and advanced biomarkers. Thank you for your time and attention.
Thank you, Dr. Tiny, for that wonderful talk. Sir could not join as he was traveling. Dr. Chopra has joined. Sir, a few words from you. I think you are joining from a different time zone. So before moving to the
I'm in Seattle right now. Landed yesterday. But it was a wonderful talk. I think it tells us a lot about. Tiny has really highlighted those points that judicious utilization of clinical techniques gives us so much of information and we can avoid a lot of costly tests. So, Tiny, thanks a lot for that wonderful lecture.
thank you. Over to Arun for the initiation of the clinical case discussion.
Thank you, sir. I call upon the examiners for today, Dr. Dayasagar Rao, sir, Dr. Rajshekhar, sir, Dr. Balachandra, sir, Dr. Santosh Sadish, and Dr. Shahir Ahmed to please lead the next session. And I call upon Dr. Siddiq from JIPMA Puducherry to make his presentation. I request the student panel from Sri Venkatesh Institute of Medical Sciences, Tirupati, to please turn their videos and microphones on, and please introduce yourself to the examiners.
Rohit and Dr. Wahid. Yeah.
Am I audible?
Yeah, Dr. Siddiq, you're audible.
Sir.
The student panel.
Sir, I am Wahid, sir.
I'm Rohit, sir.
Yeah.
Sir,
Okay.
speak.
Over
Can I-
to the examiners. Sir, please take over.
Yeah, Dr. Dayasagar Rao is there. He's a serial books person.
Rao, sir, you can start, sir. You're muted, sir.
Okay, go ahead.
So, good evening, sir.
Good
extremely
evening, Dr.
privileged.
Rao. I am Dr. Balachandra. Nice to talk to you.
I'm extremely privileged to be presenting a case in this esteemed forum. So today's clinical case will be about Mrs. K, a 55-year-old female, a homemaker, and she has studied till 8th standard and resident of Kadalur, Tamil Nadu, and she was a self-informant with a good reliability. Came with chief complaints of breathlessness for the last 1 year, with polyarthritis for the last 1 year, and pededema onsetting for the last 2 months, with easy fatiguity noted for the last 2 months. So these are the chief complaints. She came to cardiac OPD of JIPMER. So, history of presenting illness, patient was apparently normal 12 months back, after which she started to have breathlessness on exertion corresponding to NAHA class 2. Initially, on climbing at least 2 feet of stairs, it was initially in onset and gradually progressive to NEGA class 3 symptoms over the last 6 months, even while climbing 1 feet of stairs. And there was an history of heart failure hospitalization for orthopnea, and she was put on a medications with cardiac evaluations, after which she noted a slight improvement of symptoms. And during this episode of dyspnea and hospital admission, there was no chest pain, no cough or sputum production, no hemoptysis, and there was no palpitations associated. So dyspnea was the presenting complaint. So along with the dyspnea, while asking the history, she gave history of swelling and tenderness of the multiple joints for last 1 year. It was symmetrical, involving the small joints of both hands, with no specific presentation of any particular joint. And this joint pains was more common in the morning after waking up with stiffness, and the symptoms improved as the day progressed. She was a homemaker. As she started working, the symptoms improved. So initially involved the small joints, and then later it started involving the large joints of both knees, ankle, and elbow. And it was not like once the other joint involves, the other got relieved. It was an additive in nature, and she started feeling better on taking over-the-counter medications. And even though she felt better, but she was not completely all right, and there was no joint deformity. And along with the polyarthritis, for the last 1 year, she noticed increased cold sensitivity. Usually, while washing at home, she used to feel numbness while washing utensils, and this usually used to return after resting for some time. So, for the last 4 months, she also noted a dry ulcers on the tip of the fingers and toes. So, after that dyspnea and polyarthritis symptoms, she started noting to have pededema, bilateral lower limb swelling, for the past 3 months, which was initiation onset, gradually progressive in nature, and it was up to lower one third of the leg, and it improved with the medications prescribed after the heart failure hospitalization. And there was no abdominal distension, no right hypochondrial pain, and there was mild reduction in urinary output for the last 6 months, and there was no hematuria nor frothy urine, and she noted loss of appetite for the last 3 months. And for the last 2 months, she also had complaints of easy fatiguability, initially NAHA class 2, and it was progressing to NAHA class 3 symptoms. So there was also history of increased hair fall noted over the last 6 months while combing the hair. There was no history of fever, loss of weight, or photosensitivity, no difficulty swallowing, or hoarseness of voice, or skin thickening. There was no oral ulcers, no difficulty in getting up from sitting position, no abnormal body movements, and there was no history of syncope or TAA, and there was no history of melena. So, past history, there was no similar illness in the past, not a diabetic, not hypertensive, not a known case of OAD or seizure disorders, and no history of previous surgeries in the past. Family history, there was no family history of heart disease and no family history of sudden cardiac death. Treatment history for polyarthritis, she consulted a local practitioner. He prescribed medications, after which she felt symptomatically better but not completely relieved. So, for the last 6 months, she was on some kind of treatment for polyarthritis. And the heart failure hospitalization 6 months back, after that, she was put on medications after cardiac evaluation, including a diuretic medication, after which she started to have symptom relief. So, after the heart failure hospitalization, she came to us after 6 months. So, personal history, she was born of non-consanguineous marriage, P2L2, both normal vaginal delivery, and last childbirth 25 years back, non-smoker, non-alcoholic, mixed diet, and appetite is normal, rest all normal, and she attended menopause 8 years back. Summary, sir, can I proceed? Sir, can I proceed with summary, sir?
Yeah, please go ahead.
So, summary, a 55-year-old male with no known comorbidities presenting with symmetrical additive arthritis involving large and small joints with early morning stiffness and Raynaud's phenomena with digital ulcers and hair loss and worsening dyspnea over the last 1 year with recent heart failure hospitalization NOHA class 4 and pedal edema with easy fatigability favors likely a component of connective tissue disease is associated with a cardiac pathology with history of orthopnea. There is likely a severe pulmonary venous congestion, followed by a fatigability pointing towards a low cardiac output state. And with recent onset of pedal edema, I would like to keep also a possibility of biventricular failure.
Taking a leaf out of Tiny Nair's presentation, there is one study which completely gives the clinical and the heart failure, and that was the ESCAPE trial. The ESCAPE trial focused on JVP and orthoedema. So, what are the other points in the ESCAPE trial? Somebody can answer, which says that this is heart failure.
History of orthopnea is a strong indicator towards heart failure.
So actually 3 pillows or 2 pillows orthopnea and edema feet, and of course a raised JVP together with a hepatojugular reflex. So these are the points which were analyzed clinically for heart failure in the ESCAPE trial. They had a correlation with the PA catheter in position, and that showed that there was a correlation with the PCWP. One more question, and if the NYHA is 3, what is the PCWP likely to be?
More than 25, sir. 25 mm of HG. More than 25 mm of HG, sir.
Is it 25?
More than 25 mm of HG, sir.
Usually more than 25 correlates with orthopnea. If it is around 18 to 25, they will be in a symptom class of NOHA class.
Can you just describe what is orthopnea?
So, when a patient usually having symptoms even in the morning with exertion, once goes to sleep, immediately after sleeping, patient has to not comfortable at sleeping and develop dyspnea and has to sit for some time.
So why does that happen?
So,
Not able to lie flat?
So,
what is
after
the,
sleep,
what is the hemodynamic explanation
so immediately
for
after
failure
sleeping,
to lie down flat?
so on lying down flat, immediately after sleeping, so increased venous return to the decompensated ventricles causes pulmonary venous congestion. So increased venous return immediately after lying down.
Pulmonary venous congestion results in
interstitial
edema followed with how does edema occur? What determines the edema?
Based on LA mean pressure, if it is elevated already.
No, generally you said pedal edema, pulmonary edema. So what is the hemodynamic, determinant of the, what is edema? Edema is increase in the interstitial fluid. So what drives the hydrostatic? Yeah,
Yeah.
fluid
Hydrostatic pressure.
Hydrostatic
Yeah.
pressure and oncotic.
and what
Oncotic pressure.
and what holds the pressure? What holds
Oncotic.
the water within the
Oncotic
vessel?
Oncotic pressure.
So basically, that means the fluid has to leak out and then cause
That
congestion.
capillaries.
Cause congestion, and then it becomes a wet lung, which is difficult to expand compared to at a time when the lung is filled with the air. So your answer should be the hydrostatic pressure has to be more than the oncotic pressure for the fluid to load to get into the interstitial space. So what is the normal oncotic pressure? Hello,
What
am
is
I
the-
audible?
Yes, sir.
Yeah. So what is the normal oncotic pressure?
8 to 10.
which is the major determinant of the plasma oncotic pressure?
25 to 28, 25 to 30 millimeters of mercury.
Yeah. And that is influenced mostly by
Serum
By-
albumin.
Albumin.
that's the protein, right?
Proteins.
Proteins. So
Okay.
basically, if you say that somebody asks, what is the hemodynamic in a patient who has got orthopnea, that means it must be on the borderline, 25 to 30, or to be more precise, it has to be the pulmonary venous pressure has to be more than the oncotic pressure, assuming that the plasma proteins of that patient is 25 to 30 millimeters of mercury. So the pulmonary arterial wedge pressure or the LA pressure here in this patient has to be 25 to 30 millimeters of mercury. What was the interesting aspect of the escape trial which Dr. Balchandar was asking? Do you normally correlate the jugular venous pressure with right side of the heart or left side of the heart?
Side of the
Right
heart.
side.
Sorry?
Right side of the heart, sir.
Right side of the heart. And what was that study show? Escape trial?
Correlated with PCWP.
So PCOD is what? Represents what?
LA mean pressure.
Yeah, LA mean
EVD.
pressure. So it is representing the LA filling pressure, not the RA filling pressure. Usually we say, what are the signs of right heart failure? We say dependent edema, elevated engorged jugulars, and enlarged and tender liver. All are only systemic venous circulation. So basically, that study showed for the first time, I think Perlov was one of the authors, I think, in that study. And then they correlated that the rise in jugular venous pressure is a reflection of the pulmonary arterial wedge pressure. But then if you think back, what is the commonest cause of right heart failure?
Left heart failures.
Yeah. So that is the reason. So there are exceptions to it, but by and large, if you say elevated jugulars clinically, we say it is equivalent to right-sided heart disease. Maybe wall, maybe ventricle, that kind of a thing, we look at it. But coming back to this patient, 55-year-old female with no major risk factors for coronary artery disease, presented mostly with joint pains and Raynaud's phenomena and left heart disease. So to put these three things together. So which connective tissue disorder affects the left side of the heart?
Systemic sclerosis.
Systemic sclerosis.
Systemic sclerosis, how does that affect the left side?
Restrictive cardiomyopathy, sir.
Fibrosis of the heart.
Can involve in multiple ways. Either a post-inflammatory myocarditis and post-myocardial fibrosis, or due to something called as coronary Raynaud's phenomena. Multifactorial or pericardial involvement and myocardial involvement.
All connective disorders can involve all the three layers, endocardium, myocardium, pericardium. But you're telling systemic sclerosis because?
More of a fibrotic component will be noted in systemic sclerosis.
So fibrotic component involving the left side of the heart, not the right side of the heart.
Can involve.
Is pulmonary hypertension more common with systemic sclerosis or any other connective tissue disorder?
More common with systemic sclerosis, one of the localized variant. And
Yeah,
isolated
it is basically, a severe pulmonary hypertension. That is basically because of
depends upon whether it is diffuse systemic sclerosis or localized systemic sclerosis. Diffuse systemic sclerosis, there will be a more ILD component. It could be secondary to lung pathology, but in CREST syndrome, it will be a primary due to vascular component without ILD.
So according to you, it is the ILD that causes the right heart failure.
So in diffuse systemic sclerosis, ILD predominantly contributes to PH, but in localized CREST variant, it is a vascular remodeling that contributes to PH in localized CREST variant, where PH is very severe.
Okay.
So what
Raynaud's
about this
phenomena? Raynaud's
Raynaud's
phenomena.
phenomena?
What? Raynaud's phenomena with what do you call dry ulcers at the tips of the
Raynaud's
finger?
phenomena could be either primary Raynaud's or secondary Raynaud's. Primary Raynaud's phenomena is likely benign finding, but secondary Raynaud's phenomena will be with ANA positive and secondary to connective tissue diseases. And if you do a nail fold capillaroscopy, there is a distortion of the capillary architecture. So primary Raynaud's phenomena, we need not treat it. So avoiding the winter and wearing clothes will be sufficient for primary Raynaud's. But secondary Raynaud's, secondary to CTDs, needs management with vasodilators.
No. Which connective tissue disorder has got a very high incidence of Raynaud's phenomenon?
Systemic sclerosis.
CREST syndrome.
CREST syndrome.
Okay.
What about the joint involvements, the progressive joint involvements? Is this a feature of progressive systemic sclerosis, especially large and small joints?
Unlikely,
Worse
sir,
in the morning?
less likely systemic sclerosis involving joints in this fashion. There could be a component of some other CTD along with systemic sclerosis. Could be overlap syndrome or could be MCTD. Like this.
Yeah, could be overlap now.
Systemic sclerosis is a disease of males or females, which is more common?
Females. More
Females.
common.
Females.
So basically, what is against the diagnosis of a SLE, systemic lupus erythematosus?
No photosensitivity per se is noted, sir.
Okay, any other? So your first diagnosis will be connective tissue disorder, but it is basically a left heart disease. So you need to think an unusual component to the connective tissue disorder. Usually they often present to the cardiologist with PAH, and further investigation turns out to be a connective tissue disorder. But
SLE, sir,
here is
SLE is less likely.
SLE
is less likely. Renal involvement is also less, sir. In this case, renal involvement will happen early in SLE compared to other CTDs. It's not there.
Yeah, okay, agreed. But
so other than connective tissue disorders, what other conditions can you, of course, your history is quite clear, but still.
Yeah.
There is left heart involvement.
Which is predominantly involves the left heart.
Since there is a component of CTD and inflammation, there could be a CAD component also underlying. Accelerated atherosclerosis possible with this inflammatory CTDs. So that we should keep in mind.
Okay,
so what makes you to think that it is a, what do you call, left heart disease due to fibrosis of the endocardium or myocardium?
Patients came with a recent heart failure hospitalization of orthopnea, favoring a severe pulmonary venous congestion. So likely raised LA filling pressures and LVDP rising with ECP difficulty pointing towards a low cardiac output. So LV systolic failure we are expecting.
Let's see the physical findings apart from that.
So general physical examination, patient is conscious, oriented, comfortable at rest, height of 152 centimeter, weight of 50 kgs, BMI is 21.6 kilogram per meter square, And currently, patient is not overloaded, sir. She was on diuretics for the last 6 months. Mild pallor, no icterus, no cyanosis, no clubbing, and no lymphadenopathy. And there was pitting pedal edema noted till lower 1/3 of left, and a dry pitted scar noted in the tip of fingers and toes. And the mouth opening being normal, no skin thickening, no skin rashes, and no deformities of joints. So pulse 100 beats per minute, regular in rhythm, normal volume, and all peripheral pulses equally palpable. No vessel wall thickening, and no radioradial or no radiofemoral delay. Blood pressure, right upper limb 104 by 72 millimeter of mercury, left upper limb 102 by 74, and left lower limb 110 by 76 with no much of variation. Respiratory rate was 18 per minute, thoracoabdominal, saturation of 90 to 99% with room air. JVP was elevated 2 centimeters from the root of the clavicle in sitting position, and normal A and B waves with normal X and Y descents. So, inspection and palpitations, chest wall appears symmetrical, trachea is in midline, no precordial bulge. Apical impulse is noted in the left 6th intercostal space, 1 centimeter lateral to mid-clavicle line, localized to 1 intercostal space. It was LV type with middle traction and no specific character, normal in character. And a grade 2 parasternal heave was noted. No thrills, no pulsations over chest or epigastrium or suprasternal region, no scars, dilated sinus or veins. Upper border of liver corresponding to right 5th intercostal space, right cardiac border corresponding to right sternal border 1 centimeter lateral, left cardiac border corresponding to apical impulse, left second intercostal space is dull. On auscultation, there was a normal first heart sound, and second heart sound, there was a loud pulmonary component with normal IoT component, and the heart sound is normally split. S2 component is normally split, and a low pitched diastolic sound heard burst over the cardiac apex with below the stethoscope. LVS3 with no variation with respiration or dynamic auscultation, no other added sounds, and no murmurs here. So other system examinations, respiratory, normal vestibular breath sounds, no added sounds. CNS, no focal neurological deficits. Abdomen, liver palpable 2 centimeter below the right costal margin. No joint deformities, swelling or tenderness in joints. Normal range of motion in all the joints examined.
So coming back to the examination of the cardiovascular system, you said the normal volume pulse. What was the pulse pressure?
40, sir.
40?
50, sir. 50, sir.
104 by 72.
70, 50, sir.
30.
46.
Is 70, let
20,
us
20,
say
sorry, sir.
100 out of 100 by 70, it will be only
20,
30.
28, 30, sir.
Yeah, 28, 30. So you say normal volume and the pulse pressure is low. And actually the patient also complains of weakness, feeling weak, fatigue, and easy fatigability. What does easy fatigability indicate to you?
Low cardiac output state.
Yeah. So the pulse pressure is corresponding with that. So basically it is a cardiac output is decreased, and there is no evidence of pulmonary venous congestion on your physical examination.
Patient was on diuretics for the last 6 months, sir. And one explanation we can think of normal pulse volume despite a narrow pulse pressure is due to decompensated heart failure. There could be a component of vasoconstriction, peripheral vasoconstriction, making the pulse volume seem normal, even though the pulse pressure could be a little bit down the narrow aspect.
No, if there is a vasoconstriction, you will get a high volume, normal volume, or low volume. When there is a vasoconstriction,
We will be getting more of a low volume during period of shock.
so my question is only that you said normal volume and high volume. So basically, this is a case with low cardiac output. So low cardiac output and cardiomegaly.
Cardiomegaly, sir.
This
LVS3.
cardiomegaly. So what is the hemodynamic correlates of S3?
So LVS3 can happen in causes could be like LV systolic failure.
No, wait.
What
I'm
happens?
asking about the
What happens in
hemodynamic correlates of LVS3.
There is a rapid inflow of blood into the ventricles during the LA diastole.
No. So
Raised LA filling pressures.
raised LA filling pressures. What about the size of the ventricle usually when there is dilated? And that is correlated with your cardiomegaly, apex beat down and out. So that is one of the things. So in a patient with restrictive cardiomyopathy, do you expect a dilated ventricle or a not so dilated ventricle?
Not so dilated ventricle, sir.
So here is a patient with dilated ventricle.
Dilated ventricle.
And then LVS3 means there is no obstruction at the level of the mitral valve.
Mitral valve.
So that you have to take into consideration. And you said possibility of a restrictive cardiomyopathy. What will be the jugular venous pressure look like?
Elevated.
No, elevated, but what is the pattern?
So there will be a rapid wide descent due to RV complaints being affected.
No, we
There will
are
be elevated.
talking. So that is exactly the point. We are talking about LVS3 and we are evaluating jugular venous pressure.
So we are thinking in terms of restrictive cardiomyopathy with a decreased RV complaints, there could be a rapid wide descent, sir, due to rapid filling of blood in the early diastole.
No. Do you ever get a P&D in a patient who has got RV dysfunction?
Less likely.
Less likely, sir. Less likely.
So basically, the RV has to be good enough to push the blood across the pulmonary circulation to cause pulmonary edema. As a matter of fact, when the patient becomes normal, we often suspect an orthopnea that becomes, for example, classical mitral stenosis. An orthopnea disappears and the patient says he or she is feeling very well. So in a patient here, we have to explain that, going from the history, if orthopnea is used as a reliable finding, then by and large we say LV end-diastolic or LA mean pressure is elevated with a normal RV function.
Just for which occurs earlier, pathological S3 or physiological S3?
Likely pathological is dilated LV.
Physiologically dilated LV. When do you get it physiological S3?
Mostly in adolescent population, children, young adults,
Children's and
athletes, or even in pregnant higher percents.
Basically, it is a rapid filling.
rapid fillings.
Rapid filling. So, okay, so again, any murmurs you said? What is the murmur?
No murmurs also.
No murmurs.
Murmurs.
So basically, there is no murmurs, cardiomegaly, S3, and no murmurs.
Elevated JVP, the grade 2 paracental heat. The loud P2.
Is there any evidence of pH? You said
Loud, yes, sir, loud P2, sir. Loud P2, but normally split is 2 components.
Normally split doesn't exclude a PAH, but loud P2. How did you decide it was loud at the bedside?
Bedside, we can oscillate both in the pulmonary area and aortic area. So
that's not the
A2P2 component. A2P2 component. The second component is more loud here in the pulmonary area compared to the A2P2 component, where the A2 component is not so loud.
Now, what is the usual oscillatory event that we say? If that is there, then we say P2 is loud. Apart from the relative intensity, anything else that we normally use?
You have to see somewhere else and decide. Is it really?
Hangout interval could be reduced in.
No, we're not asking the mechanism. We are asking how did you arrive that there was a loud P2 was
P2.
loud. That is the thing. So normally P2 is heard at the mitral area?
No, sir, normally not there, but in case of severe PH with RV enlargement, we will be able to hear it in the apex. We have to inch towards the apex once there is a loud P2 for the severe intensity of the.
You also said left second space was resonant and no palpable sounds.
Sir, left second space is dull. Left second space is dull.
Upper border, left cardiac border,
okay.
Left second rectal space is dull. What does that mean?
So it could be dull in various causes. One of the causes is severe pH.
No, in this patient.
Severe pH. pH is there, sir. A component of pH, dilated pH.
Dilated pH, you can't say. Were there any pulsations in the second rectal space?
No, sir.
Were there any palpable component?
No, sir. No palpable component.
So basically, it is dull, but no other component of the PAH are heard. Was there a click?
No, sir. No, it doesn't click.
So basically, what are the auscultatory signs of pH?
So there could be a ESM murmur in the pulmonary area.
No. You have to tell systematically
So
at
the
the
sounds-
bedside. At the bedside, how do you make a diagnosis of what are the physical signs of
Of
pulmonary arterial hypertension?
So on inspection, we might be able to see the pulsations. We can confirm with the palpation where we palpable second out sound and
Is it there in
paracenal
this
heave.
patient? In this patient, is it there?
No, sir, no palpable second out sound.
Okay.
And we can look for a paracenal heave. So grade 2 paracenal
So
heave was
what are
there.
the auscultatory signs of?
So there could be a loud second out sound with a narrow split. And if in the setting of RV dysfunction, the split can become widened. And there could be a ESM murmur in the pulmonary area. And in case of very severe pH, we could hear a PR murmur.
Yeah, ma'am.
EDM PR murmur could also be audible.
So for this sake of pH, second heart sound loudness, always inch your step
Inch
from the
the
second
scope
left
apex.
intercostal space down to the apex.
That's-
And if we hear a loud P2, same intensity, then you are sure that it is pH, except in ASD. In
ASD.
ASD, you can still get a loud P2 in the apex, but that may not be pH.
pH.
That's basically because RA is dilated and then clockwise rotation. So that's the usual standard. You don't get ejection click or in PAH,
Yes, sir. We'll get, sir. Ejection click would be there.
a click will be there.
Dilated PS. You can get a vascular ejection clicks.
Do you get tricuspid regurgitation, murmur or no?
Yes, sir.
TR, sir. Hyperkinetic TR.
Yeah. TR is more common or PR is more common in PAH?
TR.
TR is more sensitive, but PR is more specific. Like if it is there,
No. We have, first of all, we have to recognize that.
TR is more common. TR is more common, sir.
Okay, so not convinced about pulmonary hypertension, but from the history wise, but I think physically there is evidence of right heart failure, probably secondary to the left heart failure in this patient. His primary problem seems to be left heart disease. And then we have to link this left heart disease with the more obvious manifestation of connective tissue disorder. And connective tissue disorders can rarely cause valvular heart diseases, but in this patient, according to you, there are no murmurs.
Murmurs.
Yeah. So I think we need to go to the further investigation.
What about S4?
No, sir. S4 is not audible. Only S3 was audible.
What about other people? They are Rajshekar.
Anybody? What about the other students? They are not responding. He is only responding.
Dr. Rajshekar, you have anything to? Or Santosh?
Okay, I think we will move on to the further investigations. Which one would you like to see?
Just before that, I would say that when Sir asks a question like pH, always if you want to say, of course, he asked auscultatory features, but when you say pH, always start with G wave. You may have an A wave, and if you have a TR, you may have a prominent V wave, and the X wave, the relative X and X prime will give you a sensation of how much the RV is stressed. So that also you have to tell. And then you go to the other signs, and don't forget subcostal palpation, because the RV is felt there as a true left parasternal heave can be felt in the RV. And sometimes you can get an RV S3 also there, sometimes, or an S4, especially if you are thinking of what you call progressive systemic sclerosis or other things, you can just get an S4. Okay.
Provisional diagnosis could be acute heart disease, heart failure, currently in NHA class 3 to ambulatory NHA class 4. Likely CT-related myocardial involvement.
Wait. What is your definition of ambulatory class 4?
Patients can have symptoms even at rest.
No, wait. An ambulatory class 4, you said. How can they be in class 3 and then go and then at the same time have?
So actually, she was on medication, sir. She was started on medication 6 months back. So with the medication, there is a gradual improvement.
So according to you, she was in ambulatory class 4.
At the time of hospitalization, she was in NHA class 4, sir. Even at rest,
No,
she
but
was-
then there's a difference between NYHA class 4 and ambulatory class.
after fatigue, sir, she was not able to even do the household course, and she needed assistance in the form of daughter, sir. So she was not able to even take care of the activities of daily living.
No. Ambulatory class 4 is a different definition. You have to exclude something, but to include something. That statement of ambulatory class 4 is a very specific case in which a patient has got some sort of a coronary artery disease, and you will have to exclude the patient that she is not having any active coronary artery disease. Okay, so she was in class 4 at one time. Now she is in class 3.
Class 3, sir.
Could you just elaborate to us in a female like this, what is class 3?
So less than ordinary activity, patient having symptoms of dyspnea, palpitations, fatigability, less than ordinary activity, individualized, marked symptoms.
So what activities did you ask?
So actually, sir, like in NAHO, it's like individualized. Maybe a normal activity for one person may not be normal for the other. So according to her daily styles of living,
according to your history, she was a homemaker. So you have to ask appropriate questions.
So whether she will be able to cook, sir. Maybe washing clothes will require more of med requirement. Washing clothes will be
No, washing clothes is the most strenuous of all the
most
things.
strenuous approach. So that she was not able to do right from the onset of symptoms. But even going to kitchen and cooking and drying the clothes or bathing, so this even with this she was having symptoms.
Okay. Go ahead. So
Okay.
according to you, she didn't get better than class 3.
Yes, sir. She was in NH class 3, sir. Even after starting medications.
Mm.
And she was on 6 months for the treatment, sir. Before coming to treatment, she was at least 6 months treatment compliant.
Okay.
So investigations. So ECG with a normal standardization, sinus rhythm at a heart rate of around 100 beats per minute with a normal axis with normal
wait, you can't say normal axis.
normal axis
No,
plus
you
60
have to
degrees.
define
Exact axis
Plus-
you have to.
Plus 60 degrees, sir.
plus 60.
Plus 60, sir.
I don't agree with that. Which is the least QRS complex in the limb leads?
Lead 3, sir.
Lead 3. So
Lead 3. So
it won't be 60.
See, AVL should become equiphasic. If it
plus
is
30 to
60.
plus 60, sir. Plus 30 to
It
plus
is
60.
really
Yes.
plus 30.
Plus 30 to plus 60.
No, it can't be plus 60, sir. For you to get a plus 60, it has to be equiphasic in AVL.
Yes, in AVL.
It is not. Lead 3 is the smallest.
Still positive.
Smallest.
Yeah. So it is perpendicular to lead 3. So it has to be plus 30.
Plus 30.
Yeah. Okay, go ahead.
So with a normal precaudal progression, with ST depressions noted in lateral precaudal leads, V3 to V6.
No, wait a minute. So let us ask.
Horizontal.
No. What is the role of ECG in a patient with heart failure? She is in heart failure, right?
We will be able to pick up the cause for heart failure like CAD. If it is there, we can see.
No. In this patient, what we are talking about in this patient, is there any evidence of PAH on the ECG?
There is no clear-cut evidence of RV hypertrophy or a right atrial enlargement. So
is it there or not there? PAH?
not there, sir. No evidence of.
Is there any evidence of left ventricular enlargement?
No, sir. No criteria fulfilling LVH in the ECG, sir.
So here is a patient who has got a cardiomegaly,
Really.
left ventricular apex, and no chamber enlargement on the ECG. How often you see a normal ECG in the setting of a heart failure? Any idea? Am I audible?
Yes, sir. No, not
Yeah.
sure.
So what will happen if the heart failure is there, but the ECG is sort of normal? What conditions or what do you think has happened?
So there could be a component of fibrosis, sir. This muscular mass is not so great. Dilatation is replaced by fibrotic tissue in the heart. It's a likely possibility. And even in acute stages, myocardial edema can decrease the amplitude of QRS complexes. In acute setting, myocardial edema can decrease the amplitude of QRS.
No, what is
Chronic
the ECG marker of fibrosis? ECG marker.
intraventricular conduction defects could be seen in ECG.
Intraventricular conduction defect, I mean RBB, LBB?
Yeah.
This could also be seen.
That is not the, usually it's called a splintering of the QRS.
QRS gets splintered, or there's LV dysfunction, something happens to the QRS. That is what happens. And then we think of something else which can be done.
Yes.
LBBB can occur, sir. CRT
So it
implantation.
may not be full LBBP. As you said, intraventricular conduction defects, it can be slight increase of the QRS
Duration of the
mutation.
QRS.
And what is more important nowadays, people are looking at it, is the ventricular activation time. They look at the ventricular activation time, especially leads 1, AVL, V5, V6, which are oriented towards the left side. And in case there is an increase in the left ventricular activation time, we are sure that, it is presumed that the patient may be going into either fibrosis or myocardial involvement.
So sinus rhythm is there, but no chamber enlargements as per the ECG. So let's have a look at the X-ray.
X-ray, chest X-ray AP view, situs solidus.
No, wait. We have to answer a specific question. Is there evidence of PAH?
Yes, sir. There is
Is
evidence
there
of
X-ray
PH.
evidence of PAH?
Yes, sir. There is X-ray evidence of PH.
What is the evidence, sir?
One is there is an pulmonary vasculature is more prominent with the right atrial enlargement.
Wait.
No. Don't say pulmonary
Question is very
vasculature.
specific. Question is very specific. What is the X-ray evidence of PAH?
PA dilatation we are able to see.
In this patient.
Left heart border is almost like straightened. There is a
No, that's
PA
not.
dilatation.
Any other student can answer from the swims.
Left heart border straightening occurs only because of LA appendage enlargement, not PA at all. So PA dilatation should come first, no?
Right.
No. Radiological evidence of PAH is right descending pulmonary artery.
More than
PVH is different. PAH is different.
Yes.
Pulmonary venous hypertension, what are the radiological evidence?
Antler sign, stabilization, equalization of vessels, followed with stabilization.
Stabilization is one. Okay. Second.
PA dilatation.
PA dilatation,
No.
no, we are talking about pulmonary
PVH,
venous
PVH.
hypertension.
Fluid
Curly
in
B lines.
fissure.
Curly B lines. Splaying of
Curly B.
marina due to LA enlargement.
No. Wait. You are mixing up etiology with the physical findings. We are not talking about the etiology. We are talking about radiological findings of pulmonary venous hypertension. There are about 6 signs. You will have to see how many of them are there. Is there any? There is evidence of upper lobe venous distension according to you? Is it there or not there?
It's there, sir. It's there.
So what is your evidence? Upper lobe veins have to be dilated.
Dilated.
And what happens to the lower lobe vessels?
Will be less prominent compared to the upper lobes.
What do you mean by less prominent?
Due to the
You can
fluid
say-
getting accumulated and lungs compressing the capillaries.
No. Radiological evidence of pulmonary venous hypertension means upper lobe venous distension is one of the things. What is the second one? You said Kerley lines.
Curly B lines.
Yeah. What is the third sign?
Fluid in right interlobar fissures.
Fluid in the minor fissure.
Minor fissure.
Minor fissure. Fourth,
Battering up. Yes.
That
Battering up.
no. Fourth is peribronchial cuffing.
Peribronchial
bronchial cuffing.
cuffing here.
Perihilar haze, pleural effusion,
Pleural
mostly
effusion.
on the right side. So there are 6 signs. So out of which here barely we see the pulmonary venous hypertension. Is there LA enlargement on this X-ray?
Yes, sir. There is an LA enlargement in the X-ray. Splaying of carina is there, sir.
Splaying of carina.
Playing means what is this?
So the angle between the right bronchi and the left bronchi, usually if it is like more than 80 degrees, here it is almost like 90 degrees perpendicular.
Okay. So there is LA enlargement according to you.
And RA enlargement is also more prominent.
No. We're talking about LA. So what would be the cause for LA enlargement?
In the clinical history, LVD systolic dysfunction, raised LVDP, LA mean pressure rising,
So
myocardial pathology causing dilated LA.
no, in a patient with heart failure, and according to you, there is LA enlargement and no cardiac murmurs. And there is LVS3. So LVS3, what are the hemodynamic equivalents of S3?
LA mean pressure is elevated, sir, with early diastolic filling rapidly happening during the early diastolic phase.
So what will be the Doppler flow pattern at the mitral leaflets?
E more than A.
In this
E
page.
more than A. E more than A.
E more than E, you are living in 1990s.
E more than A with E to A ratio more than 2:1, sir. With a deceleration time less than 150 milliseconds, with the middle EDAS and lateral EDAS being decreased, and tricuspid valve maximum velocity will be more than 2.8.
No, we are
with the LA volume index more than 36.
No, we are talking about
Not only the
restrictive pattern of flow across the mitral valve. So you have to tell us all the criteria of the restrictive pattern appropriately in order of importance.
E by A more than 2, sir.
More than?
Deceleration time more than 2, ratio more than 2. And deceleration time less than 150 milliseconds. Wave deceleration time. And E by E dash ratio more than 14.
No, E by E, what do you mean by that? We're talking about tissue Doppler now. We're talking about flow Doppler. So what is the third marker for restrictive flow pattern? One is E by A ratio. Second one is EDT. Third one is IVRT.
IVRT less than 50 milliseconds.
So all these three things. So what is the importance of that? Patient having restrictive pattern in spite of giving adequate drug therapy.
correct.
So your therapy is inadequate, or patient disease is refractory to the drug treatment.
Maybe patient is in advanced heart failure, or the diagnosis is not yet clear.
No. You see, once you say there is a restrictive pattern, it generally means that there is a LA pressure is high.
Right.
So what we are talking about is, in spite of giving adequate therapy, the patient continues to have the restrictive pattern. What is the prognostic implications?
Patient with heart failure on drug therapy, with symptom refractory heart failure, the mortality rate will be more, like 50% in the next 5 years. She will be thrown for mortality, sir. Symptomatic heart failure even after drug therapy. If
any other student panel is there that SWIMS students are participating or not participating?
Yes, sir. What is the M mode pattern for LV dysfunction?
M mode pattern of the mitral valve.
Of the mitral valve, sorry.
Yeah. Anybody heard of EPSS?
EP endpoint separation time will be less when there is LV dysfunction.
Not
AM movement will be
E
less.
point.
No,
E
it is
point
not
to
less.
septal.
It is not less, sir. EPSS is not less in heart failure. On the contrary, it is more.
More than 7 mm. More than 7.
What is the normal EPSS?
Less than 5 to 7 mm. More than 7 mm is abnormal.
Any other M mode marker of the mitral leaflet which says that there is heart failure?
LVEDP is increased.
No, LVDP is increased. M mode, how does it say?
There could be a cooptation defect due to dilated LV.
No. We
No,
are talking about
M-mode.
mitral flow, M-mode echo of
M-mode
the
echo.
mitral wall. Have you heard of the term called B bump?
B pump.
Yeah, what is B bump? Heard of it or not heard of it?
Nowadays not being used, but there is, you see, if you see the A to C, there will be an interruption of what is known as AC interval. So they calculate PR minus AC interval in olden days. Nowadays, they don't do that. So
Yeah.
B bump is a sensitive sign. The other point is, which is also in low cardiac output, is the anterior aortic swing. If you see the aortic swing, if the anterior aortic swing is less than 10 mm, you know that the cardiac output is also less. So these are some of the M-mode features not used nowadays, but some
Not only
examples.
that, actually, if you see the pattern of closure of the aortic wall, it is not like a box. It is something like a triangular shape. The later part of separation becomes less and less and less.
Early
Whereas
case.
normally it is something like a square. Whereas in patient with low output and heart failure, it looks more like a triangle rather than a box. Okay, they are not used now because this is the era where there was no Doppler, we were using all this. Okay, coming back to at the end of this X-ray and the ECG, what do you conclude is the possible cause of the heart failure?
On the background of CTD, likely myocardial fibrosis with LV failure progressing to RV failure with a component of PAH.
Again, you're telling PAH, and you said there is no PAH on ECG, there is no PAH on the X-ray. Okay, let's go to the next investigation.
Echocardiogram was done, 2D. This was a parasonal long axis view showing a dilated LA with dilated LV with reduced LVEF with a mild AR with normal aorta with a dilated RV, at least in this view. So the M mode across the LV showed a
Which
LV
portion
leading.
of the RV is dilated?
This will be the
Sorry?
inflow, sir.
Inflow.
No, there in this view, parasonal long axis.
Outflow.
Track,
Anterior
yes.
most outflow.
Okay, you look at the that M mode pattern of the mitral leaflet on the next to this image.
Shown on the right or left.
Yeah.
Sir.
What does it show? You think he has got a mitral stenosis?
Screen got
Or the mitral leaflet movement pattern is normal or abnormal?
then lost the screen sharing, sir.
I think we have lost the image.
Anyway, what was seen is what we discussed, the
Yeah.
EPSS.
Yes, sir. Endpoint separation time was more in this case, sir. And there was
This is E point separation, septal separation.
separation.
That's what it is. Okay.
Look at the interventricular septal.
Interventricular septal motion. How is it? And left ventricular posterior more.
It's not at all moving. It is a dilated systolic dysfunction. And look at the RV. RV size is also increased. So it is the RV outflow tract that is dilated. Is the LV wall thickness is normal or decreased or?
Interventional septal thickness was 9 mm, sir. So normal within normal range, sir.
So what is the normal thickness of the LV free wall?
9 to 12. 9 to 12.
Somebody is prompting from behind.
Yeah.
9 to 12.
So is the RV free wall thickened?
Sir, mild thickening is there. If it is more than 5 mm, usually on end diastolic frame, we will say RV thickening is there.
So in this patient, you think it is thickened or not thickened?
This view I'm not able to completely comment.
Completely do it. Okay.
In which condition the interventricular septal will show vigorous movement, but the left ventricular posterior wall will be absolutely flat. It is a type of cardiomyopathy.
Hypertrophic.
Hypertrophic cardiomyopathy.
Hypertrophic cardiomyopathy, the interventricular septum motion is flat, no? It
Absolutely
doesn't
flat.
move. The left ventricular posterior wall will move vigorously. I'm asking the reverse. The interventricular septum will move vigorously, but the left ventricular posterior wall is flat. It's
Posterior
a
wall MI.
cardiomyopathy which doesn't occur in India. It doesn't occur in Europe. It occurs only in America,
South America.
South America, yes.
Yeah.
That is
Chagas.
Chagas disease. So it's not seen, but anyway, this is just a theoretical question. Okay.
Any other investigations done for
Sir.
this patient?
So paracetamol short axis showing a reduced LVEF, level of LV. So apical four chamber view showing a mild MR with dilated LV and LA. With even the RV, there was a dysfunction, sir. It was more of a biventricular dysfunction.
Yeah.
And the Simpsons was done to calculate the EF, and LVEF was 30% with a reduced global strain, more like globally involving all the LV myocardium. So, and RV, fractional wall strain thickening was only 15%. So normally we will expect more than 35%. So there was a component of biventricular dysfunction. With RV systolic pressure assessment was done. The peak pressure was 34 millimeter of mercury with a mean pulmonary artery pressure of around 25 millimeter of mercury. So at least by
Wait a
echo there
minute.
was a
Yeah. Looking at the tricuspid ligation jet, can you guess what is the RV function? Only looking at the tricuspid jet. You say now RV function is very good or very bad or normal.
RV function is poor, sir, because
Or because
this parallel zone where there's a parabolic shape, usually if it is triangular, it is better. But the area where it is, the isovolumetric contraction time is more, we can say. This
isovolumic contraction.
time
In
is more.
isovolumic contraction, is there any movement of the blood?
Not isovolumic contraction.
Then no, but
during
this is ejection period.
Ejection time,
is
no?
more. Ejection
So
time is
it is
more.
actually, simply put it in a more scientific term, that the dP by dt
Of the
of the RV
jet.
is markedly decreased.
Not reduced.
Markedly decreased. That is the sign. So looking at that, there is RV dysfunction. Looking at TR. Okay. What is the other one?
Mean pulmonary artery pressure.
Mean pulmonary artery pressure. How much is it?
25 millimeter of mercury, sir. According to echo.
How do we calculate the mean PA pressure on this echo, on this Doppler?
Actually, I'm not able to go.
How did we calculate it?
So we will trace a jet of pulmonary regurgitation jet. We can put a continuous Doppler. The peak.
No, it is there, na?
Yes,
It
sir.
is there. So how
This
much
corresponds
is
to the mean pulmonary artery pressure, sir.
How much is it?
25 millimeter of mercury, sir.
So what is the normal pulmonary artery mean pressure?
Less than 20 millimeter of mercury.
It is 20. Anything more than that is. So not convinced about this mean pulmonary artery pressure here, more than 25. Okay, go ahead.
So the basal investigation was done with the hemoglobin of 10.7 millimeter of 10.7 grams per deciliter. With a T set of 10, there was a component of iron deficiency anemia. Ferritin was elevated because she was also having a component of inflammation. And DSR was significantly elevated, 85 millimeter per hour. And other RFT, LFTs were in the normal range. So suspecting CTD, we got an ANA done, which was negative. And the only antibodies that was positive was anti-SSA, which was RO. And all the other antibodies, including MCDD and systemic sclerosis antibodies, were all negative. Okay. So 24-hour urinary protein, there was a slight elevation, moderate proteinuria, and urinary PCR of 0.81. Nail fold capilloscopy was done, showing distorted nail bed architecture, usually seen with Raynaud's phenomena, secondary Raynaud's. TSH was subclinical elevation was there. So iron deficient anemia with high inflammatory markers with positive anti-SSA antibodies. And moderate proteinuria was there, sir.
So what does that indicate? Positive that antibody.
So it doesn't rule in anything, sir. It was non-specific, sir. It could be positive in Sjogren's, but patient does not have any feature of Sjogren's, dry eyes or dry mouth or something like that.
What is the test you do for Sjogren's?
Anti-row and anti-log.
Anti-row.
No, wait. What is the clinical criteria? Clinical criteria for Sjogren syndrome.
So clinically dry eyes and dry mouth.
No,
sir.
but how do you confirm it?
Skimmers you can do, sir.
Schirmers.
Skimmers.
Yeah. So basically,
Capillary.
yeah. Okay. So what is your final conclusion?
So we proceed with the cath study, sir, to get an EMB. So cath was done for the patient. Pulmonary artery mean pressure in cath was 30 millimeter of mercury, and right atrial mean was
Pulmonary artery mean pressure was 30.
30, sir. And RA mean was 9, with an LVEDP of 24 millimeter of mercury, with RVEDP of 16 millimeter of mercury, with variation more than 5, and aortic mean of 95, with a low cardiac output, cardiac index of 2.86, and the waveform was concordant and it was not discordant. And EMB was taken from RV septum, sir.
No, I just wanted to know why tissue Doppler has not been done for this patient.
Sir, since there was an clear LV systolic dysfunction.
No. Tissue Doppler, what are you
Positive.
looking at? You mean we are looking only at systolic dysfunction? Tissue Doppler?
We'll be looking at diastolic dysfunction, but
Then,
can be positive with systolic dysfunction also, sir. Doppler.
which one? Suppose if your E wave is only about 4 centimeters per second velocity, what does that indicate? If your E prime is only 4 centimeters per second, so what does that indicate?
Relaxation is impaired relaxation, sir.
Impaired relaxation.
Yes,
That is
sir.
due to
Diastolic dysfunction.
diastolic dysfunction due to, usually, how do you differentiate a restrictive cardiomyopathy from constrictive pericarditis?
Medial annulus, medial and lateral, we'll compare the E dash.
No, but
Usually-
first, apart from the other things, your E wave, E prime is exaggerated in constriction. E prime is less than 6 in
RCMP.
restrictive cardiomyopathy. So my point here is, why did you do? What was the indication for endomyocardial biopsy here?
Etiology, because we are not able to still know whether it's an inflammation or fibrosis causing the myocardial pathology, and we are
Probably, what is the best test to know whether inflammation is present or not present? Non-invasive.
Non-invasive.
cardiac
Okay,
MRI
sir.
was done, sir. Cardiac MRI was done. Once cardiac MRI was normal, then only we proceed with the EMP, sir.
Cardiac
Cardiac
MRI
MRI
was normal means
There
what
was
the
no
T1 value. What was the T1 value? You have to know
T1
the
value is 1290, sir. 1290 milliseconds, and T2 mapping was 41. It was in the normal reference range for the institute, sir.
So basically, globally, both left and right ventricles same. T1 mapping 1290,
T2
T2
mapping was 41.
Mhm.
Normal reference, sir, for the institute, and there was no hyperintensity noted in MRI, sir.
And what was the late gadolinium enhancement?
No LG, sir. No LG, sir.
No LG.
No LG.
Okay. So what did the biopsy show?
Biopsy actually showed myocardial fibers with focal necrosis and phagocytosis with admixed fibrosis and inflammation, sir. Interfacial fibrosis with inflammation by neutrophils, sir, at the focus of scarring. More of a fibrotic component with inflammation happening around the fibrotic components.
So it's like a myocarditis.
It's a post-myocarditis sequelae kind of things.
Now, if you see so much of fibrosis, then your cardiac MRI should have shown it.
Yes, sir, but actually didn't show, sir. Actually.
So
the cardiac
basically
MRI
now, they say now if you do the T2 before and after gadolinium, calculated whether the replacement fibrosis or interstitial fibrosis. That also you can differentiate.
Yes, sir.
So basically, you have to really look for a bit more advanced parameters of the cardiac MRI.
You have to use that Lake-Lewis criteria, no?
Lake-Lewis criteria for myocarditis.
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 That's what.
So Lake-Lewis criteria, what is usually found in myocarditis is basically increased edema, which should be shown in the T2 values. Okay. So what was the final diagnosis?
So we did a coronary angiogram, which revealed a normal coronaries, right dominant circulation.
So
So
these
actually,
coronaries are all splayed, splayed coronaries because of the
dilated.
dilated cardiomyopathy.
Actually, sir, there is one more entity called as cardiac Raynaud's. So usually when Raynaud's phenomenon happens, it happens peripherally. But there are case reports where there could be a patient exposed to cold can have a coronary vasoconstriction with vasospasm. On long term, they could present with LV distal dysfunction. So we did a myocardial perfusion imaging with cold provocation for this patient, suspecting it could be one of the cause. These are only some 20 case reports in the early 2000s. So it was negative study, but we ruled out the same of cardiac Raynaud's in this case. So in this case, we got an immunological consult, and they also labeled it as a undifferentiated connective tissue disease with a myocardial fibrosis bar inflammation. And patient was started on HCQs and azathioprine as immunosuppressant for the disease of both immunological nature and heart failure, along with GDMT. So this patient was under our follow-up, and actually after some 1.5 years of follow-up, we did a re-assessment. So now patient's CF is like almost normalized with a LVEF of 60%. There was a component of inflammation causing a LV dysfunction.
No, inflammation due to
CTD, sir, connective tissue disease.
connective disorder. So they treated the connective tissue disorder, and it was one of those reversible causes of
LV dysfunction.
Myocarditis. So it could be just rheumatoid with myocarditis or something like that. It has become all right.
With azathioprine and GDMT, after 1.5 years of follow-up, EF is almost normal.
But RV still looks dilated.
Yeah, RV still
RV
still looks dilated. If you see the short axis view, the
RV
still dilated. So part of it is recovering anyway. As long as the patient is recovering with treatment, that's a good sign. Probably it may take a longer time for the RV. Very interesting patient, connective tissue disorder, responding to the treatment and reversal of the LV dysfunction.
Did you give the GDMT along with the
Yes, sir.
Azathioprine.
No, GDMT was given for heart failure?
Yes, sir. She was on GDMT, sir.
Like,
so what makes you to think that it was GDMT, it was Imran and not GDMT? What makes you to think that it is the Imran that has caused the benefit rather than GDMT? My point of view is it's more common to see this kind of a thing.
Actually, the patient came to us. She was on GDMT for 6 months before she coming to us. The one drug which we added was azathioprine. And after initial 3 months, she started to show mild improvements. In first follow-up, we saw 6 months, it was 45. Then EF went to 52. Then at the last follow-up, it was... She was on GDMT before coming to us for 6 months at least.
do you think a drug like Versigouat would have been useful here? Of course, it's expensive, but there is pulmonary artery, some sort of a pulmonary arterial hypertension plus LV dysfunction. So as a pulmonary vasodilator, it could be more effective, isn't it? It's available now. Do you think it would have been more effective? I mean, I'm just asking Hari Krishnan or Sir.
Basically, Versigouat has shown improvement in symptoms, but not improvement in mortality, if I remember right. That is the so-called, what is the trial? Versigouat.
Versigouat has very little effect on the pulmonary vasculature, sir. So rather compared to Riociguat. And the pulmonary vasodilators are not very much useful in left heart disease related heart failure.
It's because it will increase input into the LV and it will cause worse.
Yes.
Okay.
Yeah. Now, are you continuing the GDMT now, or what is your plan? But
there is no clear-cut guideline when to stop the immunosuppressant for heart failure at least. So we are continuing GDMT for now. So since RV dysfunction is there, He was in NHA class 2 now.
What happened to the any idea NT-proBNPs? The values have regress or come back or remain the same?
Probably we didn't do it.
We didn't do it, okay. Because that is one of the methods of
Assessing improvement.
assessing the progression. So anyway, I think what is the take-home message you want to give?
Santosh, any
So-
comments? Santosh or Shahir, any comments?
And
So,
Rajshekhar also.
so basically,
Santosh?
the main point of presenting this case is basically not to just look at the echocardiography, but take a detailed history and examination. And say here in this case, basically MRI also didn't show any inflammation, but ultimately biopsy showed some
Sure.
inflammation and the pattern of a connective tissue disorder. We thought of giving immunosuppressant, and that actually reversed her LV dysfunction. So, thing is, look at the patient as a whole and just not look at the echo and treat heart failure. So that should be the message to be taken.
We had a series of cases like this in which the causes of early dysfunction was very different for different cases. So this is one of the cases that Shahir was managing, and then this is one of the peculiar cases where it improved drastically, and the outcome is also very good. So
how
always
much time did it take for it to improve from the starting of Immuron to
18 months. 18 months. 18 months. Sir.
So
18
initially
months?
found some improvement around 4 to 5 months,
Mhm.
but total normalization happened around 18 months.
I do not know whether you can call it total when the RV is still dilated.
Yeah, I mean, at least the LV.
Okay, I think it's
Actually,
interesting. So,
sometimes gallium 67 scans help, in such cases for myocarditis and
That's right.
can pick up residual lesions. Can
So
repeat
usually-
MRI, I think.
usually we say that, now you are giving the, what do you call, an impression that some of these cardiomyopathies, do we need to give
Treatable.
them Immuron as sort of a trial and then see whether it improves?
As a
Maybe
therapy.
measure biopsy. If there is inflammation, of course, can be tried,
No, but inflammation.
but not for all cases. I would say.
Usually, most of the literature says that the role of biopsy in making a diagnosis is now questioned, because with the advent of MRI, with advanced data on these T1, T2 values, with gadolinium, without gadolinium, all those things, do you still really believe that endomyocardial biopsy still has a place?
But clinically also
Very-
there was the polyarthralgia, polyarthritis, some that connective tissue disease syndrome that based on the immunologist advice only we started, because that also adds to the it looked like some sort of a connective tissue disorder which was
It
affecting.
looks to me that basically it is the connective tissue disorder that got controlled with the immunosuppression, and coincidentally it is not the myocarditis primarily, it is a secondary involvement.
Secondary. Correct.
So probably if there is a LV dysfunction or RV dysfunction with some clinical features suggestive of a connective tissue disorder, probably we may still think about it.
Correct.
But it is very difficult to say that MRI has not picked up information and the biopsy has picked it up. Maybe we are still learning MRI, and we are still a long way to go in the interpretation of MRI.
We recently had a 25-year-old staff nurse who presented with restrictive cardiomyopathy. MRI showed some features. We did a biopsy that turned out to be it was finally turned out to be a myeloma-like picture, and she was treated on with chemotherapy, and she improved very significantly.
Okay.
So
But maybe
it was
MRI was normal or abnormal?
MRI was subnormal, but there was no clue what was it. But the
Yes,
electrophoresis and all were normal. So we couldn't get anything. So this biopsy only was gave us the diagnosis, and she was sent to RCC, and she got treatment, and she now is on follow-up much better.
No, so according to you, what should be the indication for endomyocardial biopsy in patients with LV dysfunction or cardiomyopathies or whatever it is?
So in a restrictive cardiomyopathy, I said when there is a clear-cut, if there's no clear-cut features of a particular pattern, then we can do a DCM. I don't know whether it always indicated, but we rarely do. But in this case, we did, and that turned out to be a useful thing. So
I think it's a very interesting case.
Yeah, and also because the whole heart is involved, you could get otherwise many times it's patchy and you may miss a lesion while doing an endomyocardial biopsy. So that way MRI may be more.
Yeah, correct. Because we may not be biopsying the area where it is involved. So sometimes we may miss also. Even if you get tissues from multiple points, you may miss.
So endomyocardial biopsy still has a role in the evaluation of dysfunction where there is no obvious cause.
Yeah.
I think that should be the take-home message.
It is not routine.
We don't do it routinely, but I think here is a case where the immunosuppression was done and then patient became better. So, an improvement in LV function after therapy. Any other possible cause for a reversible LV dysfunction which can be corrected by immunosuppression other than connective tissue disorder?
Post-viral myocarditis 6-month trial could be given. There are case series where there was response in 6 months. Post-viral myocarditis can respond to immunosuppressors. Or in the initial acute stage of pulmonary myocarditis, methylprednisolone pulse steroids can have a benefit. Not so much.
Sometimes aortoarteritis also can manifest with LV dysfunction. After good immunosuppression, the LV dysfunction can get corrected.
Rajshekhar, your comments, sir. Muted, sir, you're mute.
Already all the points have been discussed in detail.
So you are this patient, you are continuing the immunosuppressants, and what is the plan of tapering, or what is the plan of long-term management of this patient?
And right now, heart failure has improved significantly. There is no trial data or data to suggest when to stop the immunosuppression. Maybe stopping, we're not sure, sir. We are just continuing for now. We got an immunological consult also for the same. For
Usually,
CTDs, we have to
the duration of immunosuppression, everything to the immunologist because primarily they are treating the connective tissue disorder. So they look at their markers and everything, and then as sir said that it is most probably we are treating the connective tissue disorder and the LV function is improving, and maybe after some time we'll have to repeat an echo after 6 months and see whether the RV function is RV has actually become much smaller than before, but it's definitely still there. Dysfunction is still there. It may improve.
See, one of the things that is suggested in the guidelines is if there is an improvement in LV function due to drug therapy, like GDMT, you're not supposed to stop it and then you're supposed to continue it, probably at a much lower therapeutic doses. Do we do the same thing here? Because connective tissue disorders are never cured in the real sense of the word.
Yes, sir. But basically, the GDMT for the heart failure therapy, we don't stop. This is unlike heart failure with
that's true. But what about the
ejection
connective
fraction?
tissue disorder?
Yeah, that connective tissue disorder, usually they have this flare-ups and then it keeps going up and down. So normally we leave that because if it is Takasua arthritis or any of these things, we usually leave the decision making to the immunologist. So usually they don't usually taper and stop fully, but sometimes, because the problem is many of these things have got long term side effects also, long term therapy. There's a balance between the risk benefit. So usually we leave it to them, and then they
Heart failure, you can stop the diuretics if the patient is asymptomatic or not having any congestion. The other EDMT 4 pillars, probably we have to continue. We don't have any data on, at least at a lower dose, probably they can be continued to maintain the benefit.
And like Sir said, you can use NT-proBNP as a guide.
Yeah, as a guide.
Okay.
And also echo subtle markers of diastolic dysfunction or systolic dysfunction in the echo leg strain also can be used to follow up these patients.
Strain was significantly improved.
C-reactive protein and ESR may be used for monitoring the activity. Maybe with that, we can try to taper these.
True.
Azathioprine.
It has been a very interesting patient. At least is an eye opener that not all patients respond, or we make a diagnosis correctly, and we do something, and then we get the diagnosis and then follow it up. But so we continue to learn every day.
Thank you, everyone. So it was a very nice case and a nice discussion. Any other points, anyone? So thank you, everyone. Very nice case, very well worked up and very well presented and discussed. So thanks to the faculty and thanks to the presenter and the students. Over to Arun and Sajan for the vote of thanks. Thank you.
I think we had a wonderful
Somebody was
session, as everyone mentioned. I think I should thank both teams from JIPMER and from Sri Venkatesh Institute, Tirupati, for the active case discussion. I should thank the examiners, Desagar Rao sir, Rajshekhar sir, Bharatchandra sir, Santosh Sadish sir, and also Dr. Shahir for the engaging discussion. And I think as to start off, we had a wonderful presentation from Dr. Tiny Nair sir, who emphasized the role of clinical medicine even in the time of AI. And I think that was amply justified by the case discussion, saying that suggesting that we should look the patient as a whole rather than from a tubular point, just looking at the heart. And that's probably what made the difference in this case. I think all the listeners would have immensely benefited from this case discussion. We continue to learn. I should thank Harishan sir, Chopra sir, and the entire team from Heart Failure Association of India, Dr. Sajan, Dr. Venugopal sir, everyone for having this clinics time and again, so that we can keep learning each time. Every case is different, as we come to know at each case session. And we'll get back next month for the next clinics. I should also make a mention of everyone who has worked behind the scenes for having this thing go on time and again. We are supported by along with Heart Failure Society of India. We teamed up with Heart Failure Society of America, who comes up with presentations every alternate month. And we have Sun from the Coronas division and Netcast and everyone in the background. Sumita has been very instrumental in getting the things done as well. So thank you all for joining us, and we'll get back next month on second Saturday with another set of teams. Over to Harishan sir.
Thank you, everyone, and good night. And we will have the next session on it will be on July 12th. It will be on July 12th, and we will tell you. I think JIPMER will be the discussions, and we'll have another institute who will be presenting the case. Thank you very much.
Thank you.
I think before we wind up, I must say that Heart Failure Society of India is trying to give the presenters the opportunity to have these case discussions be part of the journal as well. So if possible, that is something which we are trying to work out. We hope that this will give an opportunity for the case presenter also. So I think this was done excellent And even the last month's session was also done very well. So I think this will be an added motivation for those working up and presenting cases at the heart failure
So
clinics.
if you can give us a write-up of this case, no, we will add the discussions which these eminent faculty has discuss the points. We'll include everything and publish as a case so that it can be useful for the students who are coming later. So can you please share those images and the write-up? We can write it as a case report and send to us. We'll add the discussions and publish it as a.
Sure.
Okay, Santosh,
We'll plan. Thank you.
Thank you very
thank
much.
you so much and good night.
Thank you so much.
Vinay, you can close the session.